Namaste and a very, very good afternoon, doctors. I'm Dr. Srikanth, National Manager, Scientific Services, Himalaya Wellness Company, Bangalore. I'll be the moderator for today's webinar, Fatty Liver, Pivot of Metabolic Disorders by Dr. Sandeep Satsangi. On behalf of Himalaya Wellness Company and MedTalks, I extend a very hearty welcome to you all. It's indeed my privilege to welcome and introduce Dr. Sandeep Satsangi for today's webinar. Incidentally, today is also International NASH Day. Welcome, Dr. Sandeep.
Thanks, Dr. Srikanth. I'll just share my screen.
Before that, I'll just give you a very brief introduction of Dr. Sandeep Satsangi. He's a consultant hepatologist and a liver transplant specialist. He did his MBBS training in Hyderabad and has secured distinction in various subjects, including pharmac, microbiology, SNPM, pediatrics. He completed his MD in internal medicine from KMC Mangalore in 2014. He was the university topper and acknowledged as best outgoing student. Later on, Dr. Sandeep pursued his DM in hepatology from PGI Chandigarh and has been extensively trained in the field of liver diseases and liver transplantation. He has topped the exit exam of DM hepatology held at PGI Chandigarh as well. Today, Dr. Satsangi is one of the finest liver transplant surgeons in India. The medical practitioners has been associated with various reputed hospitals in India, and the physician, and he is currently working as a consultant Apollo Hospitals, Bannerghatta Road, India. If you look at his research publications and papers, he has several publications in various international and national journals and has authored many book chapters as well. Tackling the burden of hepatitis C in Punjab, India, chronic hepatitis C, suspect, detect and treat, recent advances in medical management of portal hypertension, how will I manage CHC genotype 1 after introduction of direct acting antivirals? These are some of his well-known articles. He has also served as the assistant editor of the Journal of Clinical and Experimental Hepatology in 2016-17, which is the official journal of the Indian National Association for Study of the Liver. As mentioned earlier, he's one of the leading hepatologists and liver transplant specialists based in Bangalore with a thriving experience of over 7 years in the field. He's currently working as a consultant hepatologist at Apollo Hospital, Bannerghatta Road, Bangalore. Please note the question and answer session will be at the end. Please do key in your questions. Over to you, Dr. Sandeep.
Yeah, thanks for the kind introduction, Dr. Srikanth, and thanks IJCP to organize this session on a very important day, which is the 9th of June, which is the International NASH Day. So basically, this day is primarily aimed to create awareness about this very sinister entity called as non-alcoholic fatty liver disease, which very silently is going to come to you and it's going to affect your liver and it's going to cause progressive fibrosis in the liver in some patients and leading on to cirrhosis and liver cancer. So today's topic is more or less going to cover this entire spectrum of fatty liver. I'll try to be more concise and clinical oriented rather than going too much in depth into boring textbook related material. I'll be trying to cover it in introduction, wherein I'm going to talk about the spectrum of NAFLD, what are the most important metabolic risk factors because of which you can be at risk for NAFLD. How do you diagnose this? What do I do it when I diagnose NAFLD? The basics on pathogenesis, treatment, how would I currently treat fatty liver, and what are the newer therapies, because this is where a lot of molecules are being now tried to treat the spectrum of NAFLD, most importantly, non-alcoholic steatohepatitis. So the prevalence of NAFLD is approximately 35%, 30 to 35% in India, which is shockingly high. And especially when you take the diabetic population of India, some studies have reported prevalence as much as 75 to 90%. Chronic liver disease due to NAFLD is slowly becoming the commonest cause of cirrhosis or HCC requiring a liver transplant. And once you are developing a NASH-related cirrhosis of liver, more than 45 to 50% of such patients are going to decompensate in 10 years. And not only cirrhosis, but also the incidence of liver cancer is increasing. And the biggest risk factor is that not only with the onset of cirrhosis, but even before the onset of cirrhosis, patients of NASH can develop HCC. So that is the most scary thing. Earlier, this phenotype of development of HCC without cirrhosis was mainly described with Hep B, Hep C, and alpha keto and aflatoxin exposure. But now it is also being described with fatty liver, especially those subgroup with NASH. So what is the basics in definition? So it's defined as the accumulation of fat in the liver in the absence of significant consumption of alcohol. So this is where we get a lot of doubt, how much is significant? What do we tell? Most of the people do consume socially, occasionally, some people daily, but very little amount. So how much is basically significant? So what we define significant as 20 grams per day, let it be for a male or a female, any quantity more than this is going to be significant amount of alcohol in consumption. Now, how do we know what is 20 grams of alcohol? So approximately 10 grams of alcohol is counted as 30 ml, a small peg of whiskey, 100 ml of wine, or a 240, a small pint, 240 ml of beer. This is akin to 10 grams of alcohol. So you can make the calculation. Anything exceeding 20 grams per day is defined as significant consumption of alcohol. So in such a patient who is having significant consumption of alcohol, if you see fatty liver, you know that the main culprit is going to be alcohol, which is causing the steatosis. Whenever you're calling your patient as having fatty liver, always try to rule out other secondary causes. Like medications, a very typical example is going to be people who are taking tamoxifen because of probably breast cancer prophylaxis, people who are on steroids. Hepatitis C virus is a very innocuous sort of a thing. When, if you miss it, you're just going to tell your patient to lose weight and exercise, but wherein he has hepatitis C virus, which is a steatogenic virus, which is going to cause fatty liver. People who are on TPN and various other rarer inborn errors of metabolism. So once you have diagnosed fatty liver, it is not enough for you to just tell that, okay, your patient has fatty liver. You need to define as what subgroup of fatty liver your patient is actually falling in, whether it is plain NAFL, which is non-alcoholic fatty liver, just the steatosis, or whether he's in NASH, which is non-alcoholic steatohepatitis. When do you call it as a NASH? By definition, NASH is a histological diagnosis. What do I mean by that? That on a biopsy, if you have any one of these three findings, that is the hepatocytes are getting ballooned, you have Mallory hyaline, or you have development of fibrosis. Any one of these features are there, then NAFL with one of these features is called as NASH. So you need to look at whether your patient is developing NASH or not, whether he has already gone into a stage of F4 fibrosis, that is NASH-related cirrhosis, or he has developed HCC, which is liver cancer. So you have to substratify your patients of fatty liver, NAFLD, into either one of these categories. Now, again, $1 million question is going to come, that a patient is fat and also has alcohol. Now, this was one study which I had done when I was at PGI. I don't want to bore you with a lot of studies, but what this study basically showed, that those patients who actually have cirrhosis and who have associated metabolic syndrome, the severity of cirrhosis was actually much higher. So metabolic syndrome is common in patients with alcoholic cirrhosis, and the presence of metabolic syndrome might be contributing towards the severity of liver disease. That means that just because you have alcohol consumption and associated bad metabolic phenotype can worsen or accelerate your disease progression. This was particularly done in the subset of patients with cirrhosis. Okay. A very important finding, which most of the people actually go about, is that I have fatty liver. I look at my LFT. If my SGPT or my ALT is normal, that means I don't have NASH. Is this concept actually true? So up to 80% of patients with non-alcoholic fatty liver disease have normal ALT. Patients with normal ALT can also develop progressive disease and NASH. However, if you have a persistently elevated ALT, yes, this can be associated with disease progression. And there is no designated ALT cutoff to actually say that your patient is having not plain steatosis, but has NASH. So there is no particular cutoff for you to say that whether this goes in favor of NASH or NASH with fibrosis. So ALT is a very, very non-specific marker, which we need to understand. So what are the tests which you would routinely order when you're looking at a patient with metabolic syndrome and fatty liver? That is hemogram. You are going to look at the liver function test. You're going to look at the viral markers, because as I told you, hepatitis C and hepatitis B have to be strictly ruled out. You're going to look at the lipid profile in the fasting situation. You're going to look at hypothyroidism. You're going to look at the diabetic profile of the patient. You're going to image the patient just by ultrasound, and you have to try to non-invasively assess the fibrosis. There are some methods by which you do non-invasive assessment of fibrosis. One is by simple blood test. There is something called as non-alcoholic fatty liver fibrosis score, NFS, what we call as, and one which is called as FIB4 score. So these two are very simple scores which use your platelet count, AST, ALT, and you enter it in a calculator and you're going to get a value. I'm going to show you that. But a more sensitive way of identifying whether your patient has fibrosis or not is by doing imaging techniques like transient elastography, which is fibroscan, or other modalities like MR elastography, wherever these are available. So this is a very commonly used thing right now. So we should know about this. This is a fibroscan machine. It has two probes, which are the M probe and the XL probe over here, which you can see. And this is how the report is going to get generated. This over here is what is called as the CAP score, which tells you about the amount of fat in the liver, steatosis in the liver. And the most important thing to look at is the one in the right, which is the LSM, which is the liver stiffness measurement. So any LSM which is more than 8 is going to indicate that your patient is going into anything more than F2 fibrosis. So ideally, you would always want a LSM less than 6 or 5. But if it is slowly escalating and if it touches your cross a limit of 8, that's when you should be worried that maybe some amount of underlying fibrosis is going on, though your ALT might be normal. So this is how it's going to help you. These were the two fibrosis score, the NAFLD fibrosis score, the NFS, and the FIB4 score. You can see the cutoffs over here. So if the FIB4 score is less than 1.3 or the NFS is less than minus 1.4, you can very reliably exclude a significant fibrosis. That is a F2 fibrosis. But if you have a FIB4 or NFS more than 2.67 FIB4 and NFS being more than 0.6, you have to evaluate these patients in much more detail, because these patients might have underlying significant fibrosis. But the problem is the gray area. In this gray area, usually you need to rely on other modalities like transient elastography or MR elastography. What is the role of liver biopsy? Very important, obviously, to make a diagnosis of NASH. I was telling you that you need a liver biopsy ideally in order to diagnose NASH, but not only that, but also to look for fibrosis. With Mason's trichrome, you can easily make out the amount of fibrosis. But another important finding is going to be rule out concomitant liver diseases. Very, very important point which you're going to have. Whenever, for example, you have some reports which are not completely in favor of a fatty liver. For example, you have a female patient who is obese, who has elevated liver enzymes, who has fatty liver on ultrasound, but her ANA report, her autoimmune markers come positive. You are in doubt that this patient, whether she's suffering with a plain fatty liver or whether she's suffering with autoimmune hepatitis. In these situations, definitely you have a lot of idea by doing a biopsy. Or if the patient is taking any over-the-counter medications which is not prescribed by a practitioner, and maybe that medication is causing a drug-induced liver injury, that also can be missed out, and you might just assume that it is fatty liver related hepatitis, which is NASH. So you need to do biopsy to rule out those situations. Very brief in pathogenesis, we need to understand that the entire pathogenesis revolves around two hits. One is the primary hit. The primary hit is basically your situation which is causing steatosis. That means that my metabolic phenotype is worsening. Slowly, I'm becoming more sedentary. I'm becoming more obese. I'm not doing exercise. I'm eating a lot. My liver is getting filled with fat. It might be in a plain stage of steatosis. It is not harming me. Nothing is happening. So I'm okay. This is a plain steatosis, which is NAFL, which we call. Then what happens is something else happens. Now, this something else can be environmental factors. It can be genetic factors. It can be gut dysbiosis. So many things will happen in the second hit, wherein you're going to have a lot of mitochondrial dysfunction. You have a lot of cytokine, adipocytokine imbalances. You're going to have a lot of oxidative stress coming up, and you're going to have hepatocyte ballooning and inflammation setting out in the liver. So that's the reason there is a lot of variability. Some people will be obese, but will only have steatosis. Some people are hardly overweight by 2 to 3 kgs, and they have fatty liver, but also associated NASH and fibrosis. That is because the second hit is usually very, very variable. In the genetics, especially in India, there's a lot of genetic abnormalities in the ApoC3 gene. Whenever you have abnormalities or polymorphisms in the ApoC3 gene, you have more tendency to develop NASH. Similarly, other gene in people who are interested is the PNPLA3 gene. Any polymorphisms which are not favorable also can lead on to more NASH. So genetic factors, gut dysbiosis, environmental factors, severity of your metabolic syndrome, all will contribute to the second hit, and which will put your patient from NAFL to NASH, that is NASH. In the metabolic syndrome, we basically look at these 5 components, that is central obesity, presence of impaired fasting glucose or diabetes mellitus, presence of hypertension or dyslipidemia in terms of 2 most important, that is hyper TG, any TG which is more than 150, or low HDL, that is any HDL less than 50 in females or less than 40 in males. So I remember when I got a photo of this mannequin when I was back in Punjab, and a very typical thing which you can see over here, that, this is, I think, the sad state of most of the Indian males, that, this is how they are now looking. Most of the people have a visceral adiposity, that is a paunch, and this is what is actually accentuating the metabolic syndrome. So coming to the cutoffs, now this is an important point because this is unlike the Western cutoffs. So the waist circumference for you to call central obesity is, the cutoff is 90 centimeters for males and 80 centimeters for females. And even your BMI cutoffs are a little different when compared to the Asia Pacific and the Western counterparts. For Asia Pacific, you have a lower cutoffs. So ideally, you need to have a BMI less than 23. Somewhere between 18 to 22.9 is a normal BMI. If you're anywhere more than 23, you're already overweight. And if you're going anything more than 25, you're in the category of obese. Okay, now this is also an entity which we very, very commonly seen in India, which is lean NAFLD. What is lean NAFLD? That actually by the cutoffs of the waist circumference and by the BMI, these guys are normal. These patients are completely normal. Their BMI is less than 23. But when assessed properly, they have much more intra-abdominal, that is the visceral adiposity, when compared to the Western counterparts. Despite having a smaller waist, when you actually scan them, you see that the internal fat is actually more. So to look at outside, they are more or less just 1 kg, 2 kg overweight, or maybe just right bang at 23, 24 BMI. But still, when you look at their internal side, you will actually see that they have a very bad visceral adiposity. In fact, they also have insulin resistance. So the treatment goals are more or less same. The lifestyle changes will be applicable even for lean NAFLD, but you need to remember about this entity called as lean NAFLD. So what do I basically do? This was one wherein I wrote up about this, what do we do when we see fatty liver? So first important is point is to find out that it's a metabolic disorder. So try to find out your metabolic components properly. Get your assessment of your thyroid, sugar, blood pressure, dyslipidemia profile, and most importantly, those secondary causes which we were discussing over here, like hepatitis C virus or drugs, which most commonly many people will be actually taking. So you need to exclude that. And after that, you need to actually have an idea that in which patient has a higher chance of progression. So female sex, age more than 45 years, associated severity of metabolic syndrome is very important markers that this patient might actually have a progressive disease. Based on the lab parameters, I spoke to you about 2 scores, high NAFLD fibrosis score, high FIB4 score, or as simple as the AST-ALT ratio. If the AST-ALT ratio, so take the AST SGOT and divide it by the SGPT. If that is more than 1, that would indicate that there might be underlying fibrosis which is developing in your patient. You might have to evaluate them further. So if any of these risk factors are strongly there, or the other risk factor which I told you that you are confused with some other disease happening, you have to do a biopsy in those patients in order to confirm that this patient is not in plain steatosis, but in NASH. So you can see over here, liver biopsy should be considered in patients, especially who have high risk for developing NASH or advanced fibrosis, and in those patients in which you're suspecting competing etiologies is very, very important. So what are the current approaches? As of now, what are you using? What are the drugs most commonly you're using? And what is the ASLD guidance? And what are now the latest therapies which are now being tried out? So many drugs are in the armamentarium now. We are going to discuss in brief about these drugs so that we get an overview about what are the present things and what are the latest things which are happening. Before that, people who are actually, into the treatment of fatty liver and who actually follow studies of fatty liver will now in every study notice these 2 points. That is, every drug which is being evaluated has to actually try to look at these 2 aspects. Either it should be targeting a NASH resolution, or either it should be a drug which is targeting fibrosis improvement, or Always better is if a drug which can do both. So NASH resolution basically means that you reduce the NASH scoring, which is the non-alcoholic steatohepatitis scoring on the biopsy. You have a score based on which the pathologist is going to grade it, but that drug should not worsen the fibrosis. So you should have a NASH resolution without worsening of fibrosis. But if the fibrosis worsens, though the NASH is getting resoluted, the drug is not meeting the primary endpoint. Similarly, for fibrosis improvement, any improvement in the fibrosis stage by one stage or more without worsening of steatohepatitis, then you can say that the fibrosis improvement endpoint has been met. So now most of the times you're going to look at the drugs which are being targeted these two pathways. The most important point in order to explain to your patient is lifestyle modifications in order to attain a sustained weight loss. So it is very easy for us to just pass on a message saying that you need to lose weight, but we have to be more objective. How much weight does a person need to lose? So if we are looking at NASH resolution, the person should at least lose 7% of body weight. And if you're looking at fibrosis reduction, that means your patient should at least target 10% of weight loss. That means if a person is somewhere around 100 kgs, I would tell my patient that he should lose at least 10 kgs over a period of 1 to 1.5 years. And after that, he has to sustain the weight loss. It's not that he'll lose it and again he'll gain the weight. So you can't expect a complete fibrosis reduction. So this is the basic pyramid which you need to explain to your patient. So the most important recommendation, more than any medication out there, is going to be lifestyle change, wherein you're going to tell your patient about calorie deficit diet. You're not going to give an advice that my patient has fatty liver, so you reduce the fat. Only reducing fat is not going to be working. There should be calorie reduction. That means calories coming from any source, let it be sugar, let it be fat, let it be just rice items. From any source, calories coming in should be curtailed by at least 500 to 1000 kilocalories per day. And you have to increase the output by 30 to 40 minutes of moderate intensity exercises. Typically, what you can advise your patients is maybe 30 to 40 minutes of brisk walking, not a normal walk, but a brisk walking. And that should lead to a sustained weight loss. So you're going to give them a target. So ideally, as I told you, we need to come down to a BMI target of 23, but for many of the situations that is not going to be possible. So at least 10% of weight loss, and you have to sustain that weight loss by continuing your lifestyle changes. Brief about some studies. This is a very, very important landmark study by Dr. Arun Sanyal, which came up in NEGM, which was the PIVENS trial, which actually looked at the placebo versus the pioglitazone versus the vitamin E. So in green is the pioglitazone, and in the blue you can see is the vitamin E. So what is the most important point is that when compared to the groups which was given placebo, there was a significant reduction in hepatocellular ballooning, lobular inflammation, and resolution of NASH, but not on fibrosis. So what the study basically told, that when compared to placebo, when you're giving vitamin E or pioglitazone, there is a significant resolution of NASH, but not fibrosis reduction. So this was a positive outcome trial saying that both vitamin E and pioglitazone work very well. Subsequently, a study actually came up in those patients, particularly with having diabetes. And again, a similar finding was found that, there was no improvement in fibrosis using pioglitazone versus placebo, but there was a significant resolution of NASH. Look at the p-value being so significant, and with a significant reduction in the NASH scoring on biopsy. Vitamin E was also evaluated. This was a recent study which was evaluated in those patients with advanced fibrosis or cirrhosis. That means the boat has already sailed, your patient is already in cirrhosis. But even in that stage, this study showed that those patients who are actually taking vitamin E, the one in the orange you can see over here, those patients who are taking vitamin E had a better transplant-free survival and a lower hepatic decompensation when compared to those patients taking placebo. So vitamin E is found to be beneficial not only in earlier stages of NASH, but also in those patients who have advanced fibrosis or cirrhosis. So vitamin E, usually approximately 800 units, international units per day is the recommended doses. There has been some concerns of vitamin E in terms of increased risk of prostate cancer and hemorrhagic stroke. Very, very few studies have shown this, but this is something to keep in mind. Pioglitazone, on the other hand, has a big headache of a side effect in terms of edema and weight gain. So imagine that you are actually telling your patient to lose weight, but you're giving a drug which is actually going to cause weight gain and edema. So that's going to be difficult. Also, especially in females, it is known to cause osteoporosis. If doctors would remember that pioglitazone came into a poor light because of there was some studies, some papers actually showed that pioglitazone can be associated with increased risk of bladder cancer, but most of the subsequent studies did not show that. So I don't think I would not use pioglitazone for that reason, but I restrict my usage of pioglitazone predominantly because of the risk of weight gain and pedal edema. What about the other drugs? Metformin, no, you wouldn't use it just upfront for any pains of NASH. But yes, if your patient has impaired fasting glucose and diabetes, high insulin resistance, and you want to give it for that purpose, you can give it. GLP-1 receptor analogs like liraglutide, semaglutide, there is some data which is coming in. It is a little premature, but some good data is coming in, which I'm going to present that to you. Pioglitazone and vitamin E, as I told you, the recommendation from the ASLD is that you would actually want to give it in those patients with biopsy proven NASH, pioglitazone in those patients with or without diabetes mellitus, but vitamin E, it is recommended mainly in those patients without diabetes mellitus. Other drugs which are commonly seen in the prescription like ursodeoxycholic acid, absolutely no role. Statin, it is not given for NAFLD per se, but in those patients who have cardiometabolic risk factors requiring a statin, please go ahead and give it. Very, very safe drugs, even in liver disease. The myth that statins are very dangerous when you have liver problem is wrong. Statins are very, very safe. So please go ahead and give statins. Omega-3 fatty acids are particularly encouraging when you're using it in those subset of patients who have hypertriglyceridemia associated with NAFLD. But otherwise, just for NASH, there has not been any conclusive evidence. So the common prescription, which we should know about. Now coming to the newer therapies, which are now hitting the phase 2, phase 3, are those which are targeting so many pathways. The first pathway, the most important pathway, is something which you can see on the left, is the insulin resistance pathway. And here is the one wherein you're going to talk about your pioglitazone, which is the PPAR gamma agonist pathway. You're talking about the glucagon-like peptide receptor agonist like liraglutide, semaglutide, basically your anti-diabetic drugs. And then you're also going to talk about drugs which affect the lipid metabolism, which is the steroyl-CoA desaturase inhibitor like aramcol and the acetyl-CoA carboxylase inhibitor, which is the firsocostat. So these two drugs, you're going to hear about it more and more because they are showing positive results in phase 2 and phase 3. Then coming to your agents which act on the lipotoxicity and oxidative stress, that is the second hit in the pathogenesis of NASH. And here you have the drug which is saroglitazar, which acts on the PPAR alpha and the gamma pathway, which is a dual receptor agonist. Also drugs which target the farnesoid X receptor pathway, which is the FXR agonist. In this, you have obeticholic acid and the newer drug, which is cilofexor. The another pathway which is being tried is targeting the thyroid hormone receptor beta agonist, which is the resmetirom, which is a newer drug which is also showing good amount of efficacy. Then comes, once imagine that your inflammation has set in, then you want to give drugs which are going to target your chemokines like CCR2 and CCR5 so that the inflammation and the immune activation can be blocked. And here is a drug called as cenicriviroc. Also, during this inflammation, there's a lot of apoptosis which is happening. So apoptosis signal kinase inhibitor, which is the ASK inhibitor, selonsertib, is also a drug which is being tried. The elafibranor, people who follow the fatty liver studies actually came with a lot of bang, but subsequently the study actually showed that elafibranor is not very efficacious and it has been now given up. So the things which are shown in red are actually not going into the subsequent phase 3 studies. So the most important table, I think, which when compared to the future armamentarium for NASH are these drugs, which is the cenicriviroc, which is the Aurora trial, which is looking at the cenicriviroc. Obeticholic acid, which is now being evaluated in the phase 3 in terms of regenerate and the reverse trial. Resmetirom is being evaluated in the Mastro trial. Aramcol, which is the steroid desaturase inhibitor, which is in the Armor trial, and combination therapies using the FXR pathway and the Celons and the apoptosis pathway. I'm going to talk about it in brief. So these are all the drugs which are now being tried in the latest studies. Obeticholic acid and saroglitazar, I think we should discuss in little more detail because they are now available to use in India. So obeticholic acid is an FXR agonist. So just activating the FXR agonist can cause so many downstream benefit. You can see over here that the most important thing is it's going to reduce or deregulate down-regulate your NF-kappa B pathway and reduce the production of pro-inflammatory cytokines like interferon and interleukin-1 production and the tumor necrosis factor production. So the inflammation wants to settle down. If the inflammation settles down, your activation of the hepatic stellate cells is less, and that's the reason your fibrosis is less. Similarly, it's going to have a very beneficial role on the glucose metabolism, and also it has a lot of beneficial role on the preventing the atherosclerosis. So FXR pathway targets lot of beneficial pathways, and that's the reason obeticholic acid was initially tried. The initial study actually came up in the Flint trial. And the problem with the Flint trial was only these two side effects, which we should remember, is that on higher doses of obeticholic acid, it is causing pruritus. And in some patients, the LDL levels are actually increasing. Then came the Regenerate trial. So the Flint trial, basically, what did it show? That both the NAS scoring improvement and also the fibrosis reduction was much better when compared to the placebo group. So Flint study was a complete success, which is why the Regenerate trial was actually done, in which case three groups were taken, one placebo, one the OCA group of 10 mg and one was 25 mg. And what was seen in the interim data was seen that the NASH resolution, if you could see, that it did not meet the primary endpoint, but it did meet the primary endpoint for fibrosis reduction, both from the 10 mg perspective and the 25 mg perspective. Though there is also a lot of data coming in that because it was an interim data, there was some improvement seen even in NASH parameters, but it did not meet clinical significance. So maybe if we wait for the complete duration of the study, we might get a positive response even on the NASH resolution. So this is what it showed, that there was improvement in lobular inflammation and hepatocellular ballooning, but it did not meet clinical significance, statistical significance, which is why as of now, the main positive impact is on fibrosis reduction. The side effects when you increase the dose is predominantly connected to pruritus and increasing LDL levels. So you need to be aware about these two side effects when you're using obeticholic acid. Also, obeticholic acid is not recommended for use in those patients of NASH with cirrhosis, because it can cause a cholestatic type of drug-induced liver injury. So be careful in that subset of patients. Saroglitazar, we were talking about as PPAR alpha and gamma agonist. PPAR alpha is mainly involved in the beta oxidation of fatty acids and the fatty acid transport, whereas the gamma, just like pioglitazone, is a very strong insulin sensitizer. So it's going to improve the insulin resistance. So saroglitazar is a combination of alpha and gamma, and there are a lot of studies which have come up in the use of saroglitazar. Initially, it was done in the mice models, and it showed that it did improve steatosis, lobular inflammation, fibrosis, all the parameters were improved, which is why in India, we took up the evidences 2 and the 3, evidences 3, which is basically a phase 3 study, evidences 2, which actually showed that using saroglitazar improved the NASH and also improved the fibrosis endpoints. This was the evidences 2 study, which was actually presented at APASL, in which you can see that in those patients who were given saroglitazar versus placebo, saroglitazar is given at a doses of 4 mg per day. There was a very significant reduction in the NAS scoring, much better when compared to the placebo group. Also, you can see this is the NAS scoring, which was significantly reduced in the group with saroglitazar. Not only that, but also it improved the liver parameters. That is the AST, ALT, which was elevated, came down very nicely, and the dyslipidemia, which is there, also improved very nicely in the saroglitazar group. So obeticholic acid, as it increased the LDL levels, that was not seen with saroglitazar. Then came the studies on humans. This was a double-blinded study. This was again by Dr. Nagachalasani's group in hepatology. So approximately 100 patients were taken in those patients with NASH with elevated ALT levels, and they were given saroglitazar in various doses. And what was seen that in those patients who were given saroglitazar, the liver fat content assessed by the imaging technique, the adiponectin levels, the insulin resistance, everything actually improved, and also the triglycerides reduced by a lot. So all the parameters of metabolic dysregulation improved, and also the liver fat content improved in those patients taking saroglitazar. Coming to the drug, which is liraglutide, which is also in the market, mainly being used for diabetes. This is a GLP-1 receptor analog. And what is a study which was done, which is the LEAN trial. So LEAN trial, what did it show? It showed that in those patients who were given liraglutide, the NASH resolution was much better. Again, not for fibrosis, but for NASH resolution, it was in 40% of patients who took liraglutide versus only 10% in placebo. This was a newer study which came again on GLP-1 receptor analog, which is the semaglutide. This recently came up in NEGM, a very recent study, which showed that daily 72-week course of semaglutide basically showed that those group which took semaglutide, there was a very significant reduction in NASH. You can see as much as 59% people, there was a NASH resolution in those patients who took the 4.4 mg of subcutaneous semaglutide. The people who took 0.4 mg also had some amount of GI side effects, but nothing major. So that also was mainly targeting the NASH resolution pathway rather than a fibrosis reduction pathway. Resmetirom, I was talking to you about, this is a thyroid hormone receptor beta agonist, again a part of retinoid X receptor family. And whenever you trigger the thyroid hormone receptor, you're going to improve the metabolism of your lipids and carbohydrates. Resmetirom, this was one study which actually was done, which again assessed the liver fat content by the MRI PDFF method, not by biopsy, by MRI PDFF. And it showed that those folks who actually took resmetirom, there was significant reduction in the liver fat content in those groups. You can see over here in the blue bar over here. Also, the study noted that a significant reduction in liver fat content is also associated with a reduction in ALT. So if you're reducing your liver fat content, your NASH is bound to improve. Then came the study targeting the chemokines, which is the Senicriviroc. This study is being done at Mount Sinai, wherein you're giving a molecule which acts on the chemokine CCR2, CCR5. So whenever you have an inflammation, you are going to have a macrophage which is going to get activated, and that macrophage under activation is going to, with the help of these chemokines, going to activate your hepatic stellate cells, which is going to cause fibrosis. So this pathway can be blocked by giving CCR2, CCR5 antagonists, and that is what is Senicriviroc. So this was a Centaur study which actually showed, you can see that there was no improvement in the NAS scoring, but however the fibrosis reduction was met. So Senicriviroc was mainly aimed for a fibrosis reduction. Selonsertib, this is what I was talking to you about in terms of the apoptosis signal kinase pathway. So what happens, if you remember the pathogenesis, oxidative stress happens, your apoptosis is stimulated, which is the ASK1 pathway, apoptosis signal 1 kinase pathway, and that via the Janus kinase pathway can cause activation of your hepatic stellate cells and fibrosis. So selonsertib is basically a ASK1 inhibitor. So selonsertib was basically tried in two studies, which is the Stellar 3 and Stellar 4 study, but unfortunately it showed that they had no anti-fibrotic effect. So selonsertib did not show, as a single agent, did not show an anti-fibrotic effect. So there's a lot of uncertainty, whether you want to target the metabolic pathway, whether you want to target the inflammatory pathway. So ideally, what personally also I believe is that you can't just target one pathway and assume that your metabolic pathways, everything is going to recover. You need to target your metabolic dysregulation. You have to give a drug for inflammation. You have to give a drug for anti-fibrotic effect also, obviously under the cover of lifestyle. So polypharmacy, that is poly-drug therapy, is usually, I think, the way out, because you want to target the multiple pathways. And this is where the most latest study is now coming, wherein you're using a combination of FXR pathway. So you can see they're using the drug called cilofexor. They are using the ACC inhibitor, which is the firsocostat, and they are trying it out. This was a study by Dr. Rohit Lumba, and you can see selonsertib, which we just discussed about, cilofexor and firsocostat are being used in all these various modalities. And now what basically was seen, you can see over here that the combination of cilofexor and firsocostat, there was a good significant reduction in the fibrosis score. So the future is basically looking at more and more poly pharmacy drugs, wherein you want to target multiple pathways and you want to get the disease under control under the proper cover of lifestyle. Because how long would you want to give the drugs? So there has to be a timeline. So obviously the lifestyle has to kick in so that you can get rid of these drugs after a point of time. So calorie deficit diet, exercise, weight loss goals, you need to very clearly emphasize to your patient. Targeting the FXR pathway by OCA, that is obeticholic acid, and the newer drug, which is a non-steroidal FXR agonist, which is the cilofexor, appears very promising predominantly for fibrosis reduction. The GLP-1 receptor agonist like semaglutide is very, very promising for NASH resolution. And the PPAR dual agonist like saroglitazar is now showing effect that it is working on both the pathways. It is causing NASH resolution and fibrosis reduction. And obviously you need more and more data, but combination therapies using your targeting your ASK pathway, targeting your FXR pathway, and probably the PPAR pathway is most logical step to target for NASH resolution. Thank you.
Thank you so much, Dr. Sandeep. It was indeed a feast on this special day. I'm sure all the doctors will take home a lot of knowledge that you have shared, the latest knowledge. There are
Thank you,
some
Doctor.
questions. Maybe I
Yeah.
think can we go ahead?
Yeah, please. Yeah.
Yeah. Yeah. Doctor has not put across their name. It is a common misconception that fatty liver is normal. In few individuals, the fatty liver can progress to cause liver damage, which leads to liver cirrhosis and liver cancer. So NAFLD is gradually marching on becoming the commonest cause of liver cirrhosis in India. How do you suggest family physicians sensitize or educate their patients diagnosed with fatty liver changes during their routine ultrasonography?
So I think bang on. That's completely right. That's the biggest concern we have. See, if most of the people who go for a health checkup, you're going to say that the radiologist is going to say that you have some fatty liver. In fact, it has become so common that I remember most of my patients actually, when I'm talking to them, would say that I just have some fatty liver. It's probably normal. So they don't understand the concept that fatty liver in some people can actually march on to develop NASH. So how do we basically ascertain, sitting in an OPD without doing a liver biopsy, how do we get to know that which patient's fatty liver is going to be significant? Now imagine the most important point which we need to understand is the associated metabolic syndrome components which are there in your patient. For example, your patient is a female. She's more than 45 years. Her duration of fatty liver, probably she has been obese for a long period of time, maybe last 15, 20 years. So the duration of having a bad metabolic phenotype and the metabolic syndrome. So, for example, out of the 5 components we spoke about, if your patient has more than 3 components of metabolic syndrome, that patient you should actually screen that whether this patient is in plain NAFL or whether it is going into NASH. Now, imagine that your patient is otherwise okay, healthy. He's probably just 1 or 2 kgs overweight. He has no diabetes. He has no hypertension. His triglycerides are normal. His HDL is normal. Maybe his BMI is only 24, and the ultrasound doctor is saying that he has grade 1 fatty liver with a completely normal LFT, and you're getting the FIB4 score and the NAFLD score, which is a easy test to be done based on your only LFT and CBC parameters. You don't need any specialized equipment for that. Most of these patients will obviously get in their serial, in the routine health checkup, CBC and LFT. So just with that, you can calculate this. And if all these things are in your favor, that this patient does not have metabolic syndrome, this patient's FIB4 score or the NAFLD NFS score is less than the what we expect. And there's a very simple app on Play Store. We can just download it, enter these parameters, and you're going to get a final value saying that you're not at risk. So just based on that, you know that this patient is not at risk. But if you do get that, okay, these patients have metabolic syndrome, maybe the liver functions are not looking abnormal, the family history is there of significant liver disease in the family, these patients should be segregated apart. And I think that patient should be seen by a specialist who can evaluate further that whether this patient has a plain steatosis or whether this patient has NASH.
Perfect, doctor. Is there any lifestyle changes apart from exercise? Are there any do's and don'ts, especially food related, specific fruits?
Yeah. So I think it has to be dual. It cannot be only exercise. It cannot be only a diet. I'm actually getting reminded of one patient whom I actually saw today morning only, who was just telling me that, sir, every day I go to one of the gym. I mean, that's cult basically, and he does a very high sort of fitness exercise. But still, he's telling that I'm not losing weight. Why? Because so when I asked about his diet, so he's a big sort of foodie, and every day he takes like 1.5 to 2 mangoes, and he takes every day he needs 2 sweets. So it's not possible that you can have only with one direction, only doing exercise and not controlling your diet. So calorie reduction is very important. Now in calorie reduction, people have a lot of misconceptions. They tell that, okay, sir, I don't eat sweet. That is not enough. So even rice has calories, even any amount of oil has calories, even your chapati has calories. So you need to know basically that what is your energy requirement. Now, if I'm a person who's completely in a sort of a sedentary lifestyle, I'm not doing any amount of exercise, and if I'm taking maybe 25 to 30 kilocalories per kg of calories, that is going to get accumulated in my body as fat. So I need to have a proper equation of how much do I need. And if I'm diagnosed with fatty liver, the first thing I'm going to restrict is calories. I don't have to restrict fiber-based foods, or I don't have to restrict protein. So I can continue to take my lean. Probably if a person is non-vegetarian, he can take his, chicken or fish, but it should again not be deep fried, but it should be, in the form of like a curry sort of a thing. But along with it, he can consume all the types of greens. He can consume fruits. He can consume all the types of dal, pulses. So these things have to increase, and the calorie containing items should reduce. Now, typical lunch plate in India is going to be so much of rice, but only a small cup of dal, so that has to be opposite. Your rice quantity should be reduced, but probably, your curry and your dal quantity should go up. So your fiber and your protein is going up, but your calorie is coming down. So just simple changes like this in the diet can reduce your calorie intake. And obviously anything which contains sugar has to be reduced. Now people have the habit of taking coffee, tea 3-4 times a day. The simple thing to advise them is you reduce the sugar intake in that by half a spoon. So their calorie intake rapidly goes down. Some people, especially teenagers, young people, are addicted to Coca-Cola, Limca, Pepsi, and these drinks. They consume it daily, one. So that contains a lot of bad things which can cause fatty liver, especially fructose containing items. So you need to avoid those things as well. So calorie reduction is very, very important. Along with it, 30 to 45 minutes of aerobic exercises. Now that aerobic exercises can be just brisk walking, it can be cross training, it can be swimming, it can be skipping, it can be cycling, but any amount of cardio exercises for a period of at least 30 to 40 minutes a day is decent enough to attain a good control on lifestyle.
Thanks, doctor. That question was from Dr. Ashish Wadhwa. There is a question from Dr. Suma. She asks, are there any preventive measures apart from these lifestyle changes and dietary modification? Once they are diagnosed, are there any preventive measures so that I have a family history or I have sedentary works lifestyle? What are the preventive measures?
So the first most important preventive measure is to actually get yourself evaluated, number one, to find out which spectrum you belong to. Just calling fatty liver, as I told, is not going to be enough. You have to find out whether your hepatologist is classifying you under plain NAFL or whether he's qualifying you under NASH. That is the first thing which he's going to do. The second thing he's going to do is assess your metabolic syndrome risk factors. How bad your diabetes is, how bad your hypertension is, how bad your BMI is. Whichever, you might not be diabetic, but you might be a high BMI person. So he's going to ascertain your risk factors. You have to attain a control on your risk factors. So if your risk factors are under control, whichever risk factor, as I mentioned, is under control, then your disease progression should definitely retard. So prevention basically is most important is follow up with your hepatologist. I would say at least biannually follow up to understand the progression. Number two is if risk factors are there, then you need to control the risk factors aggressively. People usually what happens is they get stuck to fatty liver, but they're forgetting about their diabetic control. Their HbA1cs are going more than 8.59. That it's not going to work out. You need to focus on if any risk factors which is worsening your underlying fat liver, you need to work on those. And obviously a hepatologist. So it's a multidisciplinary team usually. So what I basically do is most of the patients which I see are seen by a diabetologist, are seen by a dietitian, and are seen by a physiotherapist. Usually because we want to ascertain their physical activity, how much calories they are taking and how much should they be taking ideally, number, and how much protein they are taking. And third would be that if they have a high insulin resistance or an impaired fasting glucose, treating that as well. And occasionally even cardiologists, because most of these patients of fatty liver also have ischemic heart disease. So screening for ischemic heart disease also becomes important.
Thanks, doctor. Dr. Arun asks, how long does it take for a fatty liver to turn into cirrhosis?
So Dr. Arun, basically what happens is it's a very, very slowly progressive disease, very, very slowly progressive disease. Usually it takes somewhere around 12 to 15 years for the fibrosis slowly to march on into cirrhosis. But again, I have seen very young people. So that is the most important scary thing which I'm seeing these days. Earlier, the description was that NASH presents with cirrhosis only at the age of probably 57, 58, 60s. So that means that the problems are starting at 40 and probably a person is going into cirrhosis by 58, 60. So 15, 20 years of gap. But these days we are seeing more and more patients with this cryptogenic and NASH cirrhosis, what we call as at earlier ages, probably of, 48, 50 years. So the spectrum is becoming more and more younger. Similar thing is even happening with heart attacks. Younger people are now suffering with it. That is because probably the risk factors are starting earlier, maybe just at the age of 24, 25. Now more and more people are sedentary in their whatever work from home. They're not actively going. Even if they have to go one floor, they want to take a lift. So that's the unfortunate state right now, which is why the risk factors start early and the disease at going to cirrhosis we are seeing is early. But usual time period is around 15 to 20 years in those people who have very strong environmental triggers or genetic factors, especially PNPLA3 or ApoC3. I'm seeing patients with these polymorphisms presenting earlier, probably even 7 to 10 years of fatty liver, And when you're doing their testing, they're already in F3, F4 fibrosis. So, but by and large, around 15, 20 years. But in those patients who have family history of cirrhosis because of fatty liver, take them very seriously, because these patients definitely will have, most likely will have some problems in their ApoC3 or PNPLA.
Thanks, doctor. Just curiosity: are these tests expensive? The polymorphism.
So yeah, they are expensive. So we don't routinely do that. We only do it for patients who clear cut give a history of a family history of cirrhosis because of fatty liver. But again, the question comes: what are you going to do after getting to know about it? Either ways, your treatment has to be preventing the retarding the progression from NASH to fibrosis. The only thing, yes, you can probably prognosticate your patients better. That listen, you can't take it lightly, because this entire, the big problem is that NAFLD is not going to cause any symptoms. Imagine a person who has fatty liver having severe pain. He's obviously not going to take it. He's going to take it very seriously. But imagine now, most common scenario is patient is not going to have any symptoms. You are having necroinflammation in your liver, but you have no symptoms, which is why this is dangerous, because it doesn't cause any symptoms. People occasionally have some dyspeptic symptoms, some vague right hypochondriac pain, but nobody sees a doctor for these symptoms. So that is the reason, very important is, in all these routine checkups, when you do identify a fatty liver, don't just assume that it is a innocuous entity. You need to get it evaluated. Also get your metabolic syndrome assessed properly to see whether you're fitting into those 3 out of 5 components of metabolic syndrome or not, and then get it treated accordingly.
That makes sense. Thanks, doctor. Dr. Yogesh asks typical questions. Do you think obeticholic acid will get FDA approval in NASH?
So I do think it will, because what happens is it's a good drug. A lot of my patients are on obeticholic acid. I'm predominantly using it for those patients who are in F2, F3 fibrosis for a fibrosis reversal. As of now, I'm still awaiting data from the Regenerate trial so that whether I can use it for a NASH resolution or not. But having said that, it's a very good drug. When you are using obeticholic acid, especially in those with further high fibrosis like F4 fibrosis, you have to be careful. We have done it in research settings, and we have seen that it is causing cholestatic delete. There is also latest publication on that from the US, that whenever you are using it in F4 fibrosis, it can lead on to cholestatic type of drug-induced liver injury. So you have to be careful in that subset of patients. And second thing which you need to be careful about is that it can lead on to increase in LDL levels. So you have to keep monitoring the LDL levels. The good thing is that this LDL rise can be controlled by statins. So usually if your patient on OCA is having an LDL rise, please put him on statin. That is one thing which you can do. The second thing is also observe for pruritus. Personally, at 5 mg dose, I have not seen patients complaining of pruritus, but 10 mg, yes, maybe a quarter of them will complain of pruritus, and especially if you want to go further up, the pruritus is going to go up. I personally have not gone to 25 mg. I'm using a dose of either 5 mg or 10 mg in my clinical practice right now.
Thanks, doctor. Dr. Yogesh adds on, he has recently come across berberine ursodeoxycholate encouraging phase 2 results. He once again asks, what's your view?
Which one is that?
Berberine ursodeoxycholate.
Okay, I'm not aware of the berberine ursodeoxycholic acid. So UDCA per se. So obeticholic acid is basically a congener of that. But the point is that the OCA has a much higher agonism to the FXR pathway. So UDCA personally, I don't think is going to see a lot of light for the future armamentarium against NASH. I think it is going to go to, from UDCA, it is going to OCA. It is going to go to OCA, or in fact, more than OCA. OCA has a lot of, it's a steroidal type of FXR. So the newer drug which has come up, Silofexor, that is being more and more evaluated. It's a non-steroidal FXR agonist. So I personally think that maybe Silofexor will work better with lesser side effects when compared to OCA in pains of NASH.
Thanks, doctor. There is one case discussion. Dr. Charulata puts across, I have a patient, young mother of 30 years. She has raised serum bilirubin 1.83 milligram per deciliter with no symptoms of hepatitis, and urine bilirubin is also normal. What could be the reason for the high bilirubin level? She is not on any medication. It was just a chance finding. She is not giving any history of fever, and her HB is 13.6 gram %.
Yeah. So I'm rightly first thing I think what we need to rule out is to see the complete LFT parameters, not only the total bilirubin. You need to see whether the direct bilirubin is elevated or the indirect bilirubin is elevated. Most of the times, if you actually focus on that, it's going to be indirect bilirubin which is going to be elevated. Now, when the indirect bilirubin is elevated, look at the SGOT, SGPT. If the SGOT, SGPT is completely normal and on imaging, like for a basic ultrasound, shows that liver is completely normal, your Hep B, Hep C is negative, you just have a plain indirect hyperbilirubinemia, which is causing the total bilirubin to go up to 1.8 with a normal SGOT, SGPT. Always consider Gilbert syndrome. So Gilbert syndrome is one such phenotype wherein the total bilirubin goes up, maybe 1.82, but the direct bilirubin always is going to be normal. It is the indirect bilirubin which pushes up the total bilirubin. The SGOT, SGPT is normal. I usually get a genetic test in such patients. The genetic test is called as UGT1A1 gene polymorphism assay. When you get a small, it's a simple blood test, which is done in most of the places like Lal Path Labs and Saril. We just get that test done, and that test is going to give us an idea whether the patient is having Gilbert phenotype or not. Because what happens is you're not going to change anything. Once you know it's a Gilbert phenotype, you know that there's nothing to worry. Someday it will be 1.8, someday it will be 2.1, someday it will be 2.5, and that's okay. There are some precipitants, stressful situation, prolonged fasting, some drugs. These things can accentuate, most commonly is the prolonged fasting, wherein suddenly the bilirubin will shoot up to 1.8, 3, 3.5. Also, I have seen up till 4, but predominantly again indirect. So please look into that aspect.
So they're only reassurance, isn't it, doctor?
Yeah, once it's Gilbert phenotype, then it's reassurance. You can just document it so that in future, if the patient is going to some other doctor for some other reason, they should not start panicking that this patient has jaundice. It is just a Gilbert phenotype, which we are going to see always. It's a very, very common variant.
You were highlighting the young generation getting this particular disorder. What is your opinion about pediatric fatty liver disease, doctor? Should this be ignored till they are
so very, very good
adults?
point. I think now more and more data is now is coming up in pediatric fatty liver. See, there has been data that childhood obesity can march on to early onset diabetes, early onset fatty liver also, and also early onset fibrosis. So I would say even in the pediatric age group, we have to be very careful. Now, let's see, the entire thing is that the things are changing. I very well remember for 15, 20 years back, where were kids sitting at home with their laptop or with the mobile? And every time, we used to come back from our work, a college or school, and, probably run across to play cricket or whatever we used to do. But it was some amount of aerobic activity, and that is obviously not happening. The second thing is more and more access to junk food, which probably we did not have. Most of the people, at least I would say 15, 20 years back, did not have. We couldn't have so much of junk food right across, or our phone just to order something and eat. The kids these days, obviously the problem is their lifestyle, the diet also is getting very, very bad in terms of eating junk food, and also their sedentary lifestyle is actually worsening. And now with this COVID, things are just worse, because even for children they have to do only online classes. I'm hoping that things are now slowly starting to change, because at least if you go to school, you're in between, you're actually running around and playing with your friends. Now that also was stopped for most of the kids. So all these things, we are seeing more and more prevalence of pediatric fatty liver. Now again, it is going to be slowly progressive. So not that it is going to go into cirrhosis, but yes, a subset of those patients will definitely land up with a metabolic dysregulation. They will start developing insulin resistance maybe very early in probably 18 to 20 years of age, and you are going to see cirrhosis. So I really think that the impact is going to, I'm very sure that this change in the spectrum from 60 years diagnosing NASH cirrhosis to now coming to 50 and probably to 45 is going to happen. I think it's inevitable unless and until people change their lifestyle drastically.
Absolutely, very unfortunate. Doctor, next question is, you were mentioning about gut dysbiosis also as one of the risk factors. So what is the role of gut biome in NAFLD?
Yeah, so this is a very, very interesting new concepts which are now coming up. Basically, gut dysbiosis, I would not say is the only sole pathway which is causing NASH or anything, but what happens basically is that you might have some bad bacteria in your gut. This can cause more calorie absorption, point number one. Second, it can cause more bacterial translocation. Number two, these two things can happen. So if you have more calorie absorption, that is also not good. Number two, if you have more bacterial translocation, what happens is that those bacteria and those products, which is mainly the endotoxins, I typically mean endotoxins, that would go to the liver and would activate your toll-like receptors for TLR4, what we call as. That is what the endotoxins do. And when TLR4 is activated, it immediately activates your NF-kappa B pathway, and you have the formation of TNF alpha and interleukin-1. That causes the swelling in the liver. And if you remember the pathway, any swelling coming up in the liver is going to trigger the hepatic stellate cells, and that can lead on to fibrosis. So whether even cirrhosis, when it happens, your bile production comes down. Imagine if your patient is going to cirrhosis, and lower bile production can also cause dysbiosis. So it is both ways. You might have a bad bacteria to begin with, or you might have cirrhosis, which can further deteriorate your bacteria in the gut. So there are a lot of bacteria which are being evaluated. Most of the times, bacteria belonging to Ruminococcaceae, Lactospiraceae are considered to be very, very good. And those groups and families belonging to Enterobacteriaceae are considered bad. There has usually an overgrowth of this Enterobacteriaceae family and undergrowth of Lactospiraceae and Ruminococcaceae. And in this setting, we usually call it as a dysbiosis. And when you have dysbiosis, as I told you, this can lead on to all these downstream side effects. It might not be the only pathway, but I strongly believe that it is one of the pathway. That means that you might be obese, you might be a diabetic, you might be a hypertensive, and you also have dysbiosis. So you can't do only one thing wrong to develop with the disease. You need to do many things wrong. I mean, maybe you personally, or maybe your genetics. There should be 2 or 3 things going wrong for a disease to usually manifest.
So in this context, sorry to once again bring upon the issue of diet. Is there any diet which will help in avoiding this dysbiosis or supporting eubiosis?
So there is no, so if I talk typically about NFLD, there has been some recommendations on Mediterranean diet. Now, what is this diet? This diet typically means a diet which is rich in legumes, and the oil, especially using olive oil, has been shown to be beneficial. A diet which is rich in antioxidants and fruits, and less on your fatty acids, has been shown to be, basically this is what is called as Mediterranean diet. So I would not say that particularly only just taking a type of diet is going to change your dysbiosis into eubiosis. That is very unlikely. But yeah, having a healthy diet with good amount of antioxidants, less amount of energy dense, that is calorie dense items, is obviously going to be good. There is still some debate whether probiotics would make a difference in this situation, because what happens is you're taking probiotics, maybe that time the flora would change, but what would happen when you stop the probiotics? Would it continue, or would the dysbiosis come again? So this we still don't know. It is still not very clear. There is also data on FMT, which is fecal microbiota transplant, which is coming up in patient population with dysbiosis. Even in liver disease now it is being tried, wherein you can remove your bad bacteria and put in with a good bacteria from the stool. So, but it is very nascent stages as of now. What we know till now is that obviously because of either dietary factors or your environmental factors, your good bacteria are obviously reducing in amount and bad bacteria are overgrowing. And I think using the normal good diet, which as I told should be followed in terms of a low calorie, I mean, I would not say very low calorie, but something like a 20 kilocalories or 25 kilocalories kg per day, depending on your output. How much of it are you even spending outside with your exercise and based on your lifestyle? And at least a 1 gram per kg of good amount of protein per day, along with a diet which is rich in antioxidants, all your greens, is going to definitely promote eubiosis.
That's really wonderful, Doctor. Thank you. One more question from Dr. Rajesh. Does reducing hepatic stellate cell activation influence NASH management?
Definitely. So that is another. So basically, if you see Senicrivorog, that is how it is working at. So that drug is basically trying to act on your chemokines, which are coming from macrophages, which is going to activate your hepatic stellate cells. So in that pathway, clearly, when you're blocking that receptors and blocking those pathway, you're going to reduce your stimulation of HSCs. And when HSCs are not activated, your fibrogenesis is going to be reduced, which is one of the most important hallmark for NASH. So yes, hepatic stellate cell activation can be reduced. Also, there is some role of statins, which is being shown. Again, a very, very nascent sort of a data, which is acting on the Rho kinase, Rho kinase pathway. And that also can downregulate your activation of hepatic stellate cells. And also it has shown some role in that, and also reducing portal hypertension. But for now, there is no direct drug that it will go and down-regulate HSCs, but by these indirect mechanisms, you can actually, and any drug which is going to reduce the inflammation, you are going to down-regulate your HSC activation as well. So yes, HSC activation should be stopped so that your fibrosis doesn't happen.
Thank you, Doctor. Dr. B.L. Inkatesh asked what specific test is used to distinguish between NAFLD and NASH. I remember you had mentioned about biopsy.
Yeah. So basically, see, so you need to focus. If you take the textbook definition, it has to be biopsy. But obviously, it's not possible for a normal person to do, a normal physician to do biopsy every time in their routine practice. So you need to depend on these risk factors. And the risk factors which are clearly mentioned are female sex, age, which is more than 45, 50 years. That means your duration of fatty liver or obesity or whatever metabolic syndrome your patient is having is more. Associated at least 3 out of 5 components of metabolic syndrome, if that is there. Along with it, if you have any of the risk features, the risk scores which I told you, either and I personally rely on these 2 scores, that is the NAFLD fibrosis, that is the NAFLD score, the FIB4 score, and using the transient elastography. So if these scores show that my patient is at intermediate or high risk of underlying fibrosis, now a plain steatosis is not going to cause fibrosis. So it's obviously that my patient is developing NASH, which is causing fibrosis. That patient we need to evaluate further. Now, if you have a setup, you have to go for a biopsy. But if you're very strong that there is no other disease which is going on, absolutely there is no risk of any autoimmune problem, there is no risk of drug-induced liver injury, you know that this phenotype is happening because of fatty liver, then fine, you can go ahead and start your patient on the treatment and see the patient's response with therapy. Not that we just give therapy and forget about it. Most of these patients are also, so ALT, as I told, is not, you can't diagnose NASH based on ALT. But if this patient whom I was describing having abnormal scores, abnormal transient elastography, or your metabolic syndrome parameters are completely out of the whack, if these patients have elevated ALT levels, you would obviously want to normalize the ALT, because persistently elevated ALT levels can be associated with a faster progression of NASH. So you would obviously want to normalize it as well.
Thank you so much, Doctor. I would go ahead with one last question by Dr. Manikyam. He says, like you have highlighted about role of vitamin E. What about any other vitamin supplements, like vitamin C or like vitamin B complex? Do they have any role in NFL?
Yeah, so vitamin E, definitely there's because it's an RCT. Vitamin D, I didn't show the study. I myself have done the study when I was at PGI in those patients of fatty liver, and it did show that people who take vitamin D, and especially when you're vitamin sufficient, that is not excessive, but at least your vitamin D should be more than 30. In those patients, your good cytokines, your adiponectin levels increases, and your ALT levels normalize faster if your vitamin D levels are to the good. Because what happens is when you're vitamin D deficient, your insulin resistance can also become bad. So vitamin D, I would not say as direct therapy, but you always try to emphasize that whichever your patient is having NASH, try to ensure that their vitamin D should be in the sufficient status. That means they should not be less than 20, they should be more than 30. That should be the criteria for vitamin D. But you would not, if it's imagine more than 30, you wouldn't just give vitamin D as a therapy for NASH. You wouldn't do that. You, in that situation, obviously giving tocotrienol, which is vitamin E, would work much, much better than any other vitamin. So other vitamins you would obviously give just as a supplemental, but they would not work. There's no data that other vitamins are going to improve your NASH or the hepatocyte ballooning or the NASH phenotype.
Any natural sources, doctor? Because this like Indian gooseberry is very rich in vitamin C. Anything, any of such like vitamin E?
So vitamin E, we need to actually, so that's the reason I actually involve my dietitian. There are a lot of things which are actually good in vitamin E. Most of the times they tell that greens contain good amount of vitamin E. Even they say that what do you call, fruits contain good amount. That's the reason they always tell that the diet which is high in fruits and legumes is considered to be better in these patients, especially with and diet which is containing less amount of fatty acids, or bad fatty acids should be less. That's the reason what they say is probably diet which contains olive oil is better, is what is being seen. So I would say that the amount of vitamin E which is needed is going to be at least 800 units, and that is not possible always to consume with only amount of diet. So if you have NASH, definitely I think that you have to give at least 800 international units per day of vitamin E, and that is what you want to prescribe your patient. So for that, you need to give your supplemental vitamin E, not only rely on dietary sources.
Thank you. Thank you so much, doctor. Is there any chances of hypervitaminosis with
for vitamin E? So when I use, so what personally I do is I don't give a very long course. So I am a very ruthless person when it comes to lifestyle management. So I usually call my parents every 1 month, and I'm very strict with their lifestyle protocol. I want to see a very consistent improvement in the weight. I want to see a very consistent improvement in their energy expenditure in terms of their aerobic activity. So usually patients who come to my follow-up, they usually follow it. I would say at least 70 to 75% of patients do follow it. And in those patients, usually what happens is you're going to see a very drastic normalization of the liver function tests over a period of only 6 to 8 weeks. So I usually give vitamin E at this dose for a period of maybe 3 to 4 months, after which I reduce the dose. I rapidly reduce the dose to only 400 units, and subsequently I actually get it off also. So the problem with the therapy of NAFLD is how long to give. That's always a debate in all the fatty liver conferences, that how long would you want to give the therapy, because there's no finite time. It all depends on your patient. If whatever is driving the NASH in that patient, you need to target that. If it's a bad diabetes control, if it's a bad obesity, you need to control that. And once you control that, you can stop your whatever Evion or whichever drug you're giving, you can just get it off, so that you're not at risk of any adverse events from these drugs.
Thank you so much, doctor. On this year's International NASH Day, I think it was indeed a feast. Maybe whatever way the pathway, metabolic, inflammatory, or apoptosis or fibrotic, I think it's not a single pill that will be
Yes.
helpful. You have to look at the multidimensional.
Yes.
And thank you so much for this knowledge feast. We are really indebted. We are really indebted, from personal view, as well as on my company's behalf, Himalaya Wellness Company, as well as IGCP's Med Talks. We thank each one of you for being present here and patiently listening to Dr. Sandeep Satsangi. And I'm sure we are all fortunate enough to have 1+ hour of a busy liver transplant surgeon. I think we are all blessed. Thank you, Dr. Sandeep.
Thank you, sir.
Have a wonderful evening.
Thank you. Thank you, Dr. Srikanth. Take care. Thanks all. Bye.
Thank you. Bye-bye.